When a person has a chronic cough, there is a high probability that this person is diagnosed with asthma or COPD, also called chronic obstructive pulmonary disease. They may look like each other because both of them cause cough, chest discomfort, difficulty breathing, and noisy breathing, so that their mechanism is different. Therefore, treatment is also different. That is why we will discuss how to differentiate asthma from COPD.
Asthma is reversible inflammation of the airways. It means there are episodes when a person feels difficulty breathing and intensive cough, while in other episodes, the person can be completely fine. In the case of COPD, airways are chronically inflamed and the damage of the bronchi and lungs is progressive. There are also episodes when symptoms worsen or improve, but even in stable periods, symptoms never fully recover. So, in the case of COPD, a patient has no symptom-free days, even if they may feel better. Also, when lung function worsens, it never returns to totally normal, unlike in asthma.
Another clear distinction is the age of patients. 80% of asthma cases are diagnosed before 40, the majority of cases before 18, while almost 80% of COPD is diagnosed after 40, especially in smokers. The third important difference is the symptom pattern. In the case of asthma, symptoms fluctuate dramatically. There are good days with normal or near normal symptoms. Within those days, symptoms come and go, especially at night. Cough, shortness of breath, and wheezing can be more prominent. Symptoms can occur after clear triggers like cold air or exercise or dust and pollen exposure. On the other hand, COPD has a consistent pattern. The fourth important distinction is this. In asthma cases, the person almost always has a history of allergy, maybe allergic rhinitis or food allergy or eczema or family history of allergy. Also in the blood, eosinophils can be elevated, but it is not always the case. In the case of COPD, more commonly, C-reactive protein is increased. Also, in the blood, the percentage of neutrophils or absolute neutrophils can be elevated. Sometimes even eosinophils can also be elevated. Even in stable patients, almost 50% of cases, C-reactive protein is elevated in the case of COPD. A high percentage is seen in the case of exacerbations. The fifth important differentiating sign is the response to bronchodilators. Bista using salbutamol, a short-term beta-2 agonist in the case of asthma. Forced expiratory volume is increased importantly, more than 12%, which is defined by this spirometry test. In the case of COPD, there can be some improvement, but minimal. And sixth, in the case of asthma, cough nature is different. Asthma cough is with no or minimal sputum and has clear triggers like cold air, exercise, or dust. In the case of COPD, cough is usually with excess mucus, called a productive cough. Seventh, X-ray is usually normal in the case of asthma, although during attacks, lungs can be hyperinflated. But in the case of COPD, chest X-ray lungs are filled with residual air, called hyperinflated. It is called emphysema. 8. In the case of asthma, sputum, when present, is typically clear and white and may contain mucus plugs or spirals, called Kirschmann spirals. Eosinophils may be present in the case of exacerbations. In the case of COPD, the sputum is often more abundant, thick, and purulent, yellow or green, particularly during exacerbations. This is due to the chronic inflammation and increased mucus production in the airways. And if there is still doubt if it is COPD or asthma, the bronchial provocation test is used. It means a person inhales substances that cause bronchoconstriction, like methacillin or histamine. And in the case of asthma, breathing worsens importantly at a low dose of substance inhalation. Forced expiratory volume lowers, usually 20%, while in COPD it also can worsen, but less prominently. Although some people with mild or well-controlled asthma may have a negative test. And 10th, in the case of asthma, breathing changes several times per day. It is called diurnal variation of breathing. It is measured peak expiratory flow or forced expiratory volume in 1 second. If we measure it several times per day, it is variable during the day in the case of asthma. This variation is prominent during the day or day to day, while in the case of COPD, this variation is less prominent. And if still questionable COPD or asthma, then a response to trial therapy can be definitive. For example, start treatment with inhaled corticosteroids and observe the patient's reaction to it. If it causes reduced cough, wheezing, shortness of breath, and chest tightness, if increased FEV1, forced expiratory volume in 1 second, and peak expiratory flow. In an asthma patient, there is significant risk. In the case of COPD, inhaled corticosteroids are less effective. This observational time for inhaled corticosteroids is up to 8 weeks. Within 8 weeks, a person has a maximal therapeutic effect from inhaled corticosteroids. Sometimes a patient may have asthma and COPD overlap, both conditions together, and we should consider such scenarios also. Such cases are individuals who have had asthma since childhood or adolescence and continue to experience symptoms into adulthood, especially if they also have significant exposure to cigarette smoke. And patients with poorly controlled asthma, bronchi are remodeled and COPD develops as a complication of asthma.